So welcome everybody. I'm Eagles Milbergs. I'm a co-founder of the Healthy Community and Wellness Alliance. And I want to give a special thanks to everyone that's joined us here coast to coast. We had about 130 registrations. And special thanks to folks in Tucson, Arizona, where our nonprofit was founded last year. Conrad and I founded the Alliance when we came across a very disturbing fact about Arizona. Turns out that the state ranks 49th when it comes to the incidence of mental health problems, and also in terms of accessibility to mental care services. Now, a shocking kind of statistic. So Conrad decided to do something about it, and we set out to try to transform the system, focusing right now on three strategic priorities. One is workforce development. The field of behavioral health has a massive shortage of workers, not enough people in the pipeline. So we're trying to do something about that problem, working with our community colleges and high schools and other providers of mental health services. Second area is social determinants of health. 80% of health outcomes are a result not of direct treatment, but rather surrounding contextual issues that people live in. I mean, things like housing and employment and transportation and food and nutrition and things like that. And the third area is applying new technologies and emerging technologies. And that's what brings us to this event, which is to learn more about artificial intelligence and the role that it could play to transform how healthcare is delivered, increase access to healthcare, possibly reduce costs of healthcare, improve the accuracy of diagnosis, better treatments, and so forth. So we want to thank our speakers for being on this program. You're all fantastically talented. And I wanted to introduce Annie. Some of you may met Annie before. This is a wonderful little avatar, but let's say hello to Annie.
Hello.
Hi, Annie. We are going to have an event here with some experts on artificial intelligence and mental health. Do you have anything to offer along those lines?
Hey there. That sounds like such an exciting event. I'm thrilled to hear that you're bringing together experts in artificial intelligence and mental health. As for what I can offer, well, I may not be an expert, but I can definitely provide a friendly and supportive perspective. I've always been fascinated by the potential of AI in the field of mental health, and I'd love to join in on the conversation if you'd like. Is there a specific topic or question you want to explore?
Is artificial intelligence, can it make a difference? So what do you see as the biggest opportunity for applying AI?
Oh, absolutely. Artificial intelligence has the potential to make a huge difference in the field of mental health. One of the biggest opportunities I see is in early detection and diagnosis of mental health conditions. AI algorithms can analyze vast amounts of data, such as speech patterns, social media activity, and even facial expressions to identify potential signs of mental health issues. This could help catch problems early on and allow for timely interventions and support. Another exciting application is in personalized treatment plans. AI algorithms can analyze individual characteristics and treatment outcomes to tailor therapy approaches specifically to each person's needs. This could lead to more effective and efficient treatments, improving the overall well being of individuals. Of course, it's important to approach AI in mental health with caution and ensure that ethical considerations are in place. But with the right balance, I believe AI has the potential to revolutionize mental health care and provide better support for individuals in need. What are your thoughts on this?
Well, this has been a great conversation. So we're going to move on with our event. Thank you for taking the time.
You're very welcome. I'm glad you enjoyed our conversation. Best of luck with your event on AI and mental health. It sounds like it's going to be an amazing gathering of minds. If you ever want to chat again or have any more questions, feel free to reach out. Take care and have a fantastic event.
Thank you. Well, this is where we are. We've got an avatar here run by ChatGPT, who you can have a conversation with, and a kind of an indicator of things to come. And I think we're going to be hearing a little more about what the potential is. Well, it's now my opportunity to introduce Conrad Plimpton, an amazing guy. I'm delighted I met him through something called the Whole Brain Foundation out of Cambridge, Massachusetts, which has been working on an advanced learning methodology and framework for learning, particularly in the health area. And he's a successful venture capitalist. I think he bought his first company when he was 27, and has got a lot of activities going on in his life, a lot of other investments and so on. And he's been a very important part of getting this alliance off the ground. And so it's been a pleasure to work with him. Conrad, please share your thoughts.
Well, it's my privilege to be here and have all of you here. As the chairman of the Whole Brain Foundation, which is focused on individual wellness improvement, my CEO is Dennis Bonilla in Phoenix, who runs Wiley's, the big publishing company's academy for sharing and building talent. In my case, the first Plimpton in health was the Civil War, memorialized at Memorial Hall at Harvard, which he graduated from. And then the second was Calvin Plimpton, from the rich side of the Plimpton family, who was prominent in public health and president of Amherst, which is succeeding his father, who was a big publisher as well, and merged it into Raytheon. So their family became the largest shareholders of Raytheon in the late 60s. I'm privileged to have two granddaughters in public health, and my focus is particularly empowering women in the medical field and all fields. My wife passed her Ph.D. exams at the University of Chicago Medical School, and we've been involved in health, wellness, and positive mental focus for a long time. Thank you for coming. On with the program.
Okay. Our next important player here is Frank Velasquez with the Metro Chamber, Tucson Metro Chamber. And Frank is head of workforce advocacy for the association. And also he is director of the Healthcare Roundtable that he has on a regular basis in Tucson. So Frank, you've got the next task here of introducing people. Regarding introductions, if you go to the Eventbrite site, I'll put it in the chat, there are detailed bios that are available for every speaker. So we wanted to minimize a lot of time on reading, in many cases, very lengthy bios and CVs and so on. They're all incredibly accomplished people. So we'll make the job easier on Frank, not having to spend a lot of time introducing people. So Frank, take it away. It's your show at this point.
Sure. Thank you, Eagles, and thank you, Conrad, and thank you all for everybody being here. So quick introduction, as Eagles said, my name is Frank Velasquez Jr. I'm the Director of Workforce Advocacy here at the Tucson Metro Chamber. And unbeknownst to most of you, but I really will serve you in a good way, kind of what's happening at the Chamber. My title used to be Director of Workforce Initiatives. It shifted to Workforce Advocacy because we felt at the Chamber, our mission is championing an environment in which businesses thrive and communities prosper. And that meant digging deeper into just prescriptive initiatives, but really looking at what the barriers are to a healthy workforce. So I'm really excited about that direction at the Tucson Metro Chamber because it really does speak to building. You can't have a great economy without a great workforce. So that's kind of what we're building here over at the Tucson Metro Chamber. So I think that's enough about me. But I want to get right into the program, and I see Dr. Winslow Burleson. So hopefully I said the name correctly. Sorry if I butchered it, but would love to go ahead and start up. And the floor is yours at this point. So welcome, Dr. Winslow Burleson.
Great. Thank you, Frank. Thank you, Eagles. Thank you, Conrad. Thank you, everyone in the audience here. My name is Winslow Burleson. I'm a professor at the University of Arizona in human-computer interaction with appointments in the School of Information and Health Sciences. And I lead a group called Motivational Environments, where we're looking at how to use AI and emerging technologies, social agents, robots, wearables, to create next generation experiences that we can then evaluate for their impact in the areas of health and education. So I will share with you a few of those today. The picture you see here is the vision for a large scale major research infrastructure award called the holodeck. We proposed to the NSF that we could start to build a holodeck inspired by the Starship Enterprise, a room that you could walk into, and in the TV series, it could become anything from an entertainment center, a shore leave, to a scientific environment where you could explore how to get out, solve the challenging problems that your spaceship is facing. So we live on a spaceship. We live on Spaceship Earth, and we are all trying to solve some of those problems, some of them mental health, some of them environmental. So we envisioned the holodeck as a place that we could start to merge and bring diverse individuals and peoples and technologies together to explore these kinds of environments. And so that's the image you see here. The projects I'll speak with you today are about our supporting people living with autism with smart home environments, assessing autism risk with early diagnosis from medical records, personalized dressing assistance, a specialized case of a smart home piece of furniture, and then politeness training for healthcare providers that could help individuals attend to patients with diverse mental conditions and diverse cultures. So back in 2006, we got a project with NSF and Google called Game is Life, Life is Game. And the vision here was to blur the digital and physical environments. So if you're an athlete, or if you're going to go for a run, or if we want to motivate you to run, you might do better at your game if you're running stronger or improving in your running abilities. Or if you just ran a couple times in the last week, you would do better if you hadn't than if you hadn't. Likewise, if you haven't tried meditation, the game environment could start to help you with some meditative, relaxing, calming activities, and then that might have some benefit in your individual everyday life. And there could be any number of ways to blur that. And you can actually self-adapt those ways as well. So persistent, supportive, self-actualizing environments for health and well-being. So these are environments that you could customize and create for yourselves. And so we started to pilot these with young adults, recent graduates from college, in their homes and everyday lives, and looking at the levels of autonomy, difficulty, progress, and support they feel in different activities, and how they could adopt these kinds of technologies. And we showed that we could have end users, programmers, program these as effectively as individuals with programming backgrounds. So, making this technology more democratically available to broader contexts. We put these in a variety of homes and studied behaviors and activities and desires and everyday activities ranging from sleep to autism support, which is what we did with in partnership with the Southwest Autism Research and Resource Center in Phoenix. We developed a caregiver residential e-health toolkit where individuals could adopt pieces of the smart home technology, but also use this kind of comic strip-like authoring tool to allow individuals to create prompts for breakfast, for spending too much time on social media, for getting a call from a supportive friend or relative or teacher that would help you at a time of need. So this was our approach. In all of our projects, we advance collaborative participatory design. So working together with end user stakeholders who are the most knowledgeable about the situations that they face, and using that grounded understanding to build these types of interfaces and technologies. More recently and currently, we're developing an autism risk assessment tool for early diagnosis from medical records. So an individual, maybe a 5-7-year-old, has 5 to 7 years of medical records, but they may not have seen they may not have yet seen a provider who has classified or diagnosed autism, because in fact we have workforce development issues in that sector. We don't have enough individuals with expertise in autism to perform diagnoses. So across all the medical records of that person's life, we can start to analyze, and here you see the text analyzed in the lower right, with the conditions that are in the DSM medical standards. And so you can see here, A3, a standard, stays to herself, or the orange one here, B1, repetitive with play, variable eye contacting, lining up toys. These are small indicators individually, but collectively, they indicate that this person is likely to have autism, and the machine learning can create an assessment and provide that indication to a caregiver who may not be trained to detect autism, and then the caregiver can refer for autism detection. In partnership with nursing and geriatric and speech pathologists, we've been able to develop dressing assistants, which are smart dressers that can invite individuals who have early onset Alzheimer's or dementia and still want to dress independently and retain that level of dignity of being able to not have other people support you in a very intimate and private moment in your everyday life, the activity of daily living of dressing. We can have a dresser that would know if the dresser drawers have been opened. It could be preloaded with one garment per drawer. It can invite you by name over to the dresser, say, hey, Win, it's time to get dressed. Open the drawer with a green light. Very simple phrases that you can still follow. Take out your shirt, because now it knows the drawer is open. Close the drawer. And so if you see the caregiver interface, you can select the caregiver or loved one can indicate that I like to put my shirt on over my head first. So we can say, put the shirt on your head. If I had selected the other, it might say, put your arms into the shirt. And so you can customize to the individual nature of how they like to get dressed. You can provide continuous or intermittent support. So some days I might be doing better. My caregiver may know that, and they may select intermittent support. Other days I may need continuous support. And the AI could potentially adaptively support that as well. So providing only when needed. And then I'm also, as a caregiver, might also be able to give live support if something in the system is not yet possible. And that's an important thing with AI, is that initially we'll see collaborations between humans and the AI. So the caregiver and the AI supporting another human in their dressing activity would help all of those individuals in terms of limiting the number of fights or aggression that might occur if I were to actually walk in on somebody while getting dressed, or being able to be remote and still support the person. And then also as a caregiver, it supports my life to have this person more efficiently and effectively dressed in a shorter time frame. So all of those benefits from this activity. And the final project for this morning is a project on politeness training. So here on the left, you see the physician. Medical students are trained to interview individuals in their offices and get better and better at that. And it's a bit of a high-stake activity because they get one chance to perform this, and then they may have to go back and remediate. But with avatars that you see on the right, we can present any number of individuals with any number of conditions to physicians, and then they can, through as much practice as they feel necessary or as feedback indicates, they can get better and better at being polite. They can say their name, be sure to say their name, introduce themselves effectively, use less medical jargon, ensure that patients have opportunities to ask questions and that they're hearing those questions and responding effectively, incorporating their questions into the answers. So all of these can be both supported by AI emerging technologies as well as evaluated. And those are the types of things that we can put into the healthcare system to improve workforce training and development. I look forward to the rest of the discussion, and thank you all for coming out this morning.
Thank you so much, Dr. Winslow Burleson. So yeah, let's move right along and get our next panelist on board, and it's going to be Dr. Sarah Morris. She's chief of the Adult Psychopathology and Psychosocial Intervention Development Research Branch of the NIMH Division of Translation Research. So would love for you, Dr. Sarah Morris, to go ahead and come on forward.
Great. Are you able to see my slides and hear my voice?
We are.
All right. Thank you, everybody. And thank you so much for inviting NIMH to participate in this very interesting session. So NIMH is the country's largest mental health research funder. So my job mainly involves the pleasure of talking with scientists around the country and around the world about their research ideas and how they might apply to NIMH for grant funding for those. I am also the associate head of the RDoC unit, which is the Research Domain Criteria unit. And I'm not going to be talking much about RDoC today, but I just wanted to make everybody aware of it. It's an initiative to encourage research that looks at new ways of classifying and identifying mental disorders. So as we have advanced in behavioral neuroscience and genetics, we've really hit kind of a roadblock where the genetics and the brain organization that we're learning about don't align very well with mental disorders as they are defined currently. And so we're trying to encourage research that, for example, looks at transdiagnostic risk factors, transdiagnostic disease mechanisms, instead of being sort of cooped up by the way that diseases are currently defined. So that's a word about RDoC. I'm going to talk today about two initiatives that involve computational methods, including AI. The first one will be the All of Us initiative, and the second we're calling Impact MH. I don't have any disclosures, my required disclosures, there are none. So this is just a figure that gives an overview of this idea that there is in mental health a paradigm shift to more precision mental health, right? Because we know that everybody who is diagnosed with major depressive disorder, according to the Diagnostic and Statistical Manual, we know that there is a lot of heterogeneity within that category in symptoms and genetics and disease mechanisms involved. So instead of kind of lumping all those people together who meet those diagnostic criteria, we want to do a better job of individualizing our diagnoses and our treatment planning so that they are better able to serve individuals. And that starts with the very basic research of understanding how the brain develops and what goes wrong in brain development, using machine learning to do individual level prediction, and then using that information to do clinical trials, again, that avoid the assumptions involved with lumping people together. And then ultimately toward real world care, making better treatment decisions, making more accurate prognoses, and etc. So the first project from NIH that I'm going to talk about is the All of Us research program. And some of the people on today's session may already be aware of this initiative. It's been around for several years now. It's an enormous NIH project to enroll up to at least 1 million people to build a gigantic health database with an emphasis on including individuals who are traditionally underrepresented in biomedical research, right? So really branching out to recruit racial and ethnically diverse participants, diversity across the age range, and a diversity of health conditions, including mental health conditions, in order to create a gigantic data set that includes self-report of symptoms and functioning and other things, data taken directly from the clinical record, as well as samples of blood-based measures for genomic analyses. So NIMH is working with All of Us to implement behavioral tasks in addition to the existing measures used in All of Us, because we think that some behavioral tasks might provide a more objective measure of things like emotion processing, reward sensitivity, cognitive processing, that might be used in combination with all of the other data collected as part of All of Us to move progress toward, again, this more personalized medicine approach. So again, precision medicine is based on you as an individual, takes into account the environment, the lifestyle. in order to give healthcare providers the information they need to make customized recommendations, get better information about how to be healthier, and hopefully reduce healthcare costs, so that individuals don't have to go through a cycle of trial and error treatments and can get the best treatment for them on the first try. And so all of us is moving towards this precision health approach. So creating opportunities to identify risk factors for certain diseases, find out which treatments work best, connect people to clinical studies, and learn about technologies that could help us take these steps to be healthier. So NIMH is involved, like I said, by implementing these behavioral tasks. Those were rolled out into the All of Us platform over the summer. So we're starting to get data from really an unprecedented number of participants in an unprecedented data set on these currently 4 different behavioral tasks, but we are planning to expand that. There's interest, for example, from the National Institute of Aging to look at cognitive decline in older adults. So we do anticipate that this will be an ongoing effort to broaden the inclusion of behavioral data into All of Us. So if you have not heard of All of Us previously, I do encourage you to check out their website and sign up for the project. It's a super interesting initiative, and they need as many people as possible from across the country. So keep an eye out for it. And then the second initiative I want to talk about is more specific to NIMH. Our director of NIMH is Josh Gordon, and since his arrival, he has been specifically very interested in computational approaches, including AI, and has identified that as one of a couple priorities that he has really focused on in his first 5 years at the NIMH. And so one of the initiatives that he has really spearheaded in conjunction with the RDoC unit, the Research Domain Criteria project that I mentioned in my introductory slide. And this project is to support research projects that will take data from the electronic health record and then layer in other types of data, starting with behavioral task-based data, in order to derive what we're calling novel clinical signatures that may be more precise, more informative than the standard categorical diagnoses. So using advanced computational methods, including AI, to determine, okay, if you take the data that are available in the clinical record, like clinician notes, blood tests, hospitalizations, clinic visits, et cetera, and diagnoses that are given by clinicians, can you take all of that data and then figure out, okay, but if I add a measure, for example, of working memory, or if I ask the patient to carry or to wear an activity monitor on their wrist and try to get some sense of a sleep pattern, can we layer that information in with the existing data and improve the accuracy of our predictions about treatment response, prediction about disease course, and so on. So this is an initiative that we launched last year. The grant applications have just come in, and we will make funding decisions in the next several months. We're super excited about it. And I want to make one point about this, and I think this will probably be a theme throughout today's session. Right, the data, the outcomes and the results are only as good as the data going in, right? So we know, for example, that there is diagnostic bias to that African-American patients are more likely to receive a diagnosis of schizophrenia versus bipolar disorder. And that's a well-established diagnostic bias that appears in clinician behavior. And so we want to use this rich data set that we anticipate will come out of these impact projects to see if we can do a better job at counteracting those biases instead of perpetuating them. So this is my last slide, and I really look forward to hearing the rest of the talks and having some time for Q&A.
Hello, Frank. Are you there? All right. Well, I think we can move on to introduce. There we are, Sarah. Okay. Frank, I don't know if we've lost you. Have we lost you? It's quite possible. All right. Well, next up, I hope you can all hear me. Nod your head. Amy? Yes. Excellent. All right. So you're up. You are an entrepreneur, San Francisco Bay Area, a place I lived for 10 years, seeing the internet grow up. And you are part of that tribe that is, investing and developing and implementing new kinds of applications using AI. So take it away. We want to hear about Miri.
Thank you. That was a great intro. I appreciate that.
Yeah.
So I'm going to do a little bit of show and tell after this presentation. I'm going to let you guys kind of all play with our beta, which is free and available and accessible to the public. So we'll start with this orientation, which is if you are not every single day getting health advice and wellness advice on social media, my bet is that your kids are. And it's a huge amount. Gen Z is about 76% going onto social media every single day getting health advice. But we see this as very disorganized, really unregulated, and very fragmented. And it doesn't really hit at the heart of what we are looking for in health today, which is access to ongoing care that's personalized with the support that we need across various issues across our lifetime. That was a great introduction. I'm Amy Kelly. I'm a serial health entrepreneur and the CEO and founder here at Miri. My co-founder is Boris Kursansky. He was the first chief technology officer at Lyft. He was there for 8 years, left after it IPO'd, and is building the technical architecture of our current company. We've got Dr. Katie Rodan, who's built 2 different billion-dollar brands in wellness, Rodan and Fields and Proactive, as our strategic advisor, who I speak to all the time. And we are building a generative AI native product that ingests top health and wellness experts and makes them into your ongoing personalized coach at scale. So remember, this was super disorganized, hard to read, very fragmented. We've taken the brands, likeness, names that you already know and trust, knowledge base of the ones that you already know and trust. We've edited it out for no one selling snake oil and making sure they are who they say they are. And we've created a very streamlined product. So here they are, those very same folks that you know and trust right here, focused on your goals, proactively engaging with you. We have Miri reaching out to you. So it's not just passive. It's not just like ChatGPT. It is a coach. So reaches out, asks how you're doing with those goals. And then if you are having a different set of challenges, like you're trying to, I'll paint a picture, you're trying to lose the last 10 pounds, that you gained in a year during COVID, that you were, at home and eating more. So those are your sort of weight loss goals. You're getting help from the experts you know and trust, but then you wake up with acne. We're going to bring in the expert knowledge of that person to help you with that condition across various issues across your entire lifetime. We see this as the future of health and wellness. And now AI is finally available to forge a new type of care, which is pretty exciting. I'm going to show you a, let me first write to you the website, Miri.health. From here, you can access our public beta. I'm also going to put my email address in here for you guys. If this is getting exciting and percolating ideas, then please feel free to reach out and contact me. I'm happy to talk to you more. And I'm going to share with you our beta. I'm going to do a little live demo so you can see what it looks like. So this is the website I just put in. It kind of explains a little bit about who we are. We are building in public for a reason, because we, like everyone else that's been talking, is really obsessed with data and making sure that we are targeting the right issues for the right people. So if you go to that website I just dropped in, please click this button. It'll take you right to this beta. And I'm going to show you what the Miri beta does, which is generates a whole wellness history about who you are, your needs, creates a plan for you, gives you one actionable item. And then the next step that it will do in the next 4 weeks is recommend follow-up about that action that you can then talk to Miri in the chat, just like a real health coach, what your how your progress is. So we're trying to democratize this type of very expensive, typically concierge care, so that now it's free currently and affordable for everyone who needs this kind of personalized ongoing health coaching. I'm going to just start talking to it. Hi, Miri. I'm Amy. I am 38 years old. I have 3 kids. Tired a lot. Sometimes I walk, which makes me feel better. And I typically eat okay, but kid food is not good to be around. So this gives you an idea of where we're going with this chat and the design element, where this pulls from. The answers to this, the health questions it's asking, is actually from the proprietary data set of these experts that we partner with here. So we've got a bunch of folks. Some of them have various amounts of audience sizes. They're all published authors who are really good in their field, respectively. And this is where we're able to access the data set and content to really provide expertise for people. Okay, so let's see. I'm tired, but pretty good overall. I want to eat for less, for more consistent energy. So you can see, I mean, this is sort of an ongoing conversation. This will populate the more content I put here. So it's going to ask me what my typical meals and snacks look like. It'll create a whole nutrition plan for me, just like a personalized nutrition coach. And then these get populated. You can click on them once you fill it out, and the more it gets to know you, the better the recommendations are. And then the chat itself becomes a progress tracker, just like you're talking to a real person. So I'll stop sharing there. I appreciate showing you guys what we've been working on. We're pretty excited about how that's going to change things for millions of folks, and happy to talk more to anyone who's as excited about this as we have been. Thank you. And use the beta. So go to Miri.health, tell everyone about it. App.Miri.health is totally free and available right now for anyone who wants to use it. Thank you.
Thank you so much, Amy. We really appreciate that and look forward to the continued discussion that we're going to have today. So our last panelist, last but not least, Dr. Sophia, and I know I'm going to butcher the last name, so I apologize ahead of time. So I'm hoping it's Leite or Late. Leite, I was right the first time. Good.
It's late.
Late, I was right the second
like
time.
late,
Thank you,
late.
Sophia. So she is our translation researcher and consultant in mental health and learning technologies, powered by biometrics and AI. And the Ph.D. is in biomedical engineering with a Fulbright grant at Harvard Medical School. So thank you, Sophia, for joining us. I know I think you're far away from us, so thank you for being here.
Thank you. Let me share my screen, see if, no, wait. Sorry. Why is this not, oh, okay. Share. You
Perfect.
all see the screen, right?
Yes.
Okay, so thank you for inviting me to be present here. I'm very happy. About this topic of how AI and mental health interact, I will make an overview of what the common denominator of AI is across all systems that it's introduced. And then I will also go a little briefly on how it differently affects different users in the mental health sector, which is a particular health sector, right? I will mention some projects that I'm currently involved, and I'm happy to share more about these projects if you are interested and curious. So a little bit, I license in clinical psychology and specialize in cognitive psychology and existential body psychotherapy, and I've been practicing as a psychotherapist for 7 years now. And in parallel, I developed a research career in cognitive neuroscience and applied technology. And I studied AI, in particular neural networks, both from the perspective of how we can program artificial intelligence, but also from the perspective of how we can use it, right? And that's what I planned for today. The transversal application of AI and the particular risks and benefits for different types of users. So, global purpose AI is a decision-making support system, and it has just one goal: to decide. So it is programmed to learn how to decide based on the data that it receives, as has been talked about, and also based on the processes that compose the algorithmic structure. I'm not talking necessarily about generative AI here. I'm talking about an algorithm that is trained to deal with the data that it needs to deal and solve a task. So AI decides, and this conflicts with that high order cognitive capacity that tends to characterize humans as unique, right? Among other capacities as well. But eventually, all these capacities come together as our ability to decide. So AI, when AI decides, it exports these decisions as recommendations. And I would summarize this presentation on important question, let's say. How does the human relate with their own decision-making and with external recommendations? How does the human act in the face of these recommendations? As we go into the mental health sector, we can different stakeholders in this ecosystem have different needs and need different recommendations for their practice or for their goals, right? So for instance, I'll be talking about the clinicians and the end users as regular people who use technology to monitor themselves, to improve their health. Okay, so in terms of the clinicians, in general, clinical decision support systems are created based on objective data and also some subjective data. It doesn't matter, different kinds of data. But when it comes to the mental health sector, there is a challenge because it is very difficult to get objective data about the mental health condition of a person because it's highly subjective, right? Not many exams can shed light in this subjectivity, right? As has been talked about by Dr. Sarah before, one important challenge nowadays in the mental health and in the use of AI is actually to look for patterns in transdiagnostic that allow to understand the nature of different clinical symptoms. So we are facing a shift in mental health and in mental health practice that goes from diagnosing a disorder to diagnosing a set of symptoms in a network of symptoms that characterize a particular case, right, in a much more personalized way that allows for a much more personalized treatment. I'm involved in one of such projects that looks for neural mappings of thousands of EEGs so that the biomarkers, the neuromarkers of each clinical symptom can be found, and so that EEG exam can be used as a complementary diagnostic to this personalized diagnostic, right, of a given case. And then this institute, Neurobiose, is specialized in neurotherapy. So then a neurotherapy protocol is exported based on these neuro assessment of symptoms, and just proceeds the neurotherapy protocol as a highly personalized treatment for mental health. So in this case, the clinician will use AI to first to validate such system, but once the system is validated, to be a complementer and a support to the diagnosing and to the personalized treatment process, which is very similar to how other medical specialties or health specialties will use clinical decision support systems. But when we talk about how general users will use AI aligned with a search for a better mental health state, the scenario is quite different. There is a massive adoption of lifestyle and health and well-being applications. But in my point of view, there is a risk here. that conflicts with the main purpose of mental health from the perspective of mental health professionals. So what is this perspective? Is to promote autonomy in the person in the way that an enhanced quality of life can be maintained through a sense of agency in the daily routine, in the decision-making process, with self-knowledge, self-regulation, autonomy. And what happens, and what I see happening as a consequence of the adoption of these mental health, of these lifestyle, health, and well-being apps, is that what at first is developed with the intention of promoting the adoption of a better behavioral pattern, and with AI making recommendations on or notifications on what should be done in a given domain, becomes how can I say that, is adopted by the person as an absolute truth, and it sometimes it disconnects the person from their own self-knowledge. So one thing that is very important to combine in these technologies is the sense of autonomy, not to try that the person who's using these apps do not rely almost blindly on these recommendations. So again, an important question is, how does the user copes with their own decision-making process and with external recommendations? And based on the idea of autonomy, I will also mention two projects that I'm involved with. The first one is this photo is and the other one is Joana Melicart. She's a specialist in neurotherapy and psychotherapy as well. And it's a HALO platform. HALO stands for Human Ability Local Optimization. And the first step of this technology is an app that through the interaction with the user allows the user to increase their self-knowledge and their self-regulation. And when a given pattern of emotion, feeling, behavior is identified and the context in which this pattern occurs, it is interactions are created based on this, so to help the user to gain an insight about themselves and know what to do in a given circumstance. For instance, we all experience sadness, right? So, but sometimes it can be difficult to distinguish if I'm experiencing sadness due to the meaningful experience of my, due to a meaningful experience in my life, or if I'm experiencing sadness and that sadness is taking the shape of a clinical symptom. So this app helps the user to understand to recognize and understand the intensity of their self-knowledge, and eventually to understand if what is being felt should be if is object of professional help or not. So most of all, this looks for to improve literacy in mental health. The second project has been mentioned by Eagles, is the Whole Brain Foundation, where this technology is being created as a map, a roadmap, a personalized roadmap where the person can use their own autonomy to create their own roadmap of learning and then go through all these learning steps to be successful in this transformational change for a healthier lifestyle and behavior. Summary. AI is always a decision-making support system. And the first question we should ask is, who is this user? And how does the user make use of these recommendations? And what these recommends? So we've talked about mental health professionals and how AI is a potential tool to transform and to promote this paradigm shift in how a mental health condition is understood and treated. And for non-mental health professionals, AI can provide guidance, but importantly, it does not substitute human decision-making. It's a collaborator, not a replacement. Thank you very much. I'm open to all your questions. Thank you again.
Thank you, Dr. Sophia Late. Much appreciation for sharing that information. So I think this is the fun part of our conversation. We heard some great, some four presentations, great panelists, some great presentations from our panelists. So would love to kind of open up the floor to any questions. I can monitor the chat box if you want to enter your question there. But I think we have an intimate enough group that if you have a question, just speak it and we can go from there. And Eagles, I don't know if you wanted to add anything before we started this portion.
Well, Frank, let me kick off a question, okay?
Sure, absolutely.
The theme, one of the themes that's emerged here, maybe I'm putting this somewhat pejoratively, but the depersonalization of healthcare. I mean, taking out, if you will, the human interface and in a way substituting, a computer interface, right, for diagnosis or treatment recommendations or monitoring or whatever. So the question I have is, what's the implication of that, where maybe there's less human connection? And secondly, I think Sophia and others referred to the idea of empathy and whether AI actually has an empathetic soul or could develop an empathetic soul in order to really kind of understand the person that they're interacting with. So it's kind of a vague question, but I'm interested in what your thoughts might be on this trend of more computer interface and less human interface. Anybody? Any panelists?
Yeah, I think I would jump in to say that that can cut both ways, right? So by reducing the role of the individual provider interacting in personalized ways, you may actually, in some situations, eliminate some bias that actually doesn't serve patients very well. Every human has different biases. Every practitioner and care provider has biases that may impact their decision-making. So on one hand, eliminating some of those that can be harmful to patient care could be beneficial. But I think the flip side of that you're touching on is that there may be sort of intangible, difficult to quantify elements of the doctor-patient interaction that inform optimal care. And those may be lost in an AI setting. So I think it can certainly cut both ways, and it's something to be very cautious about and to study.
Any other thoughts? Or for that matter, we can open the answers to the audience as well. If they unmute, they can respond. This is a happy hour.
I'll just throw some thoughts. So one of the first chatbots was Eliza, and it was shown to provide some mental health benefits. It was in the late 60s to a very, very simple chat community. And so, you know, there's a rich literature of some degree of empathy, you know, right? You know, so in terms of, if you consider empathy to be some level of it understands me and provides some social connection and benefit to me, you know, I think even as Sarah was indicating, individuals for a variety of reasons don't provide necessarily the best kinds of empathy that we would like them to at different times. And so another reference that I would throw out there is a researcher by the name of Self said that a pedagogical agent, a learning companion, could care precisely. And so this is the notion that it would have an algorithm that understood when students need support and how to provide that support. And it would provide that in an unbiased way and with a rich repertoire of understanding of that patient, right? So unbiased by either predispositions to, you know, to sociocultural issues, or even by things going on in their own life. It can dedicate its entire attention to the individual in a way that, for example, a teacher might not be able to in a class of 20 students. That doesn't happen necessarily in healthcare, but we just don't get to see our providers very often. So it happens in a different kind of way. So this ability to care precisely could also be considered another type of empathetic domain.
Thank you. I do have a question from one of our attendees. So this,
Frank, I think Sophia had a quick
sure,
response.
go ahead. I'm sorry, Sophia.
Oh, okay. So when I think of an answer to this question, I always think of a paper I read, and I was trying to look it up on the web very fast. The brain ain't fooled by virtual reality. And I'm always thinking, is the brain fooled by this kind of virtual reality, virtual empathy? Like, I'm really not sure. I think that a good comfort for our brain is that we trust on the information that we are getting, and we have the sensation that the machine is considering the entire scope of information that we want to give to it, right? But I'm not sure if this comfort can be synonym of empathy. I'm not sure.
Thank you, Sophia. So I do have a question from one of the attendees. So this is to any panelist. The question is, how do people learn to use the application for both clinicians and the rest of us? And I'm assuming he's talking about normal population. Is there a learning barrier? Is it intuitive? Will those barriers limit adoption? Was Amy still on? I don't see her profile. I thought maybe she could answer this from here.
Could you repeat the question?
Sure. So basically it's saying, how do people learn to use the application, both from the clinician side and from the patient side? And is there a learning barrier? Is it intuitive? And will those barriers limit the adoption overall? I see Wynn nodding his head. So if you
I think it's an exciting, interesting challenge that we're having, for example, in the second project I mentioned with the medical records and providing an interface to clinicians who may have very limited technological experience in terms of AI. There's a number of efforts in the field of HCI looking at how to build trustworthy AI and understand the predisposition to believe the AI, or if it fails you, the subsequent disposition to ignore the AI. And so these are kind of a dynamic process for each interface. So the designers of the AI system and the way it's presented can greatly affect the way it is adopted or accessible. One of the best solutions in this context is to do, as I said in the talk, collaborative participatory design, in which you engage the end users in the process from the beginning, and you study these differences so that you tune it and optimize it for their benefits. There's a set of requirements like open AI models, open user models, editable user models. These are all part of the national debate of AI and cybersecurity and user profiling, and those are parts of the potential solutions to these kinds of questions.
Thank you. All right, so I don't know if another panelist wanted to add anything. I'll give you a minute. If not, I have another question from our attendees. I love this one. When I hear of AI, I think of Skynet. Is there any ways that AI and mental health could derail? Like, where do you see potentials for derailment? And for those that don't know what Skynet is, it's the Terminator movies where AI takes over the world. So I see some smiling faces. So yes, that's the reference. So when she hears AI, she thinks of Skynet. And are there any ways that AI and mental health could derail all the work that you're doing? So any questions from any of our panelists or any responses?
Well, I'll just make a generic comment. I'm convinced that algorithms are going to make mistakes and have accidents, right? And I suspect one of the things we need to do from a regulatory standpoint is to collect data on recommendations, let's say, that are given by AI and what the outcomes are. And if there are mistakes, I mean, this is what FDA does, right? I mean, when it comes to a drug, right? It has to approve a drug, and then it monitors the effects and side effects, right, et cetera. So I suspect we're going to have a regulatory regime at the end of the day that's going to have to maybe some kind of approval process for the algorithm, and also feedback, on what the outcomes are. And I'm convinced that algorithms are going to make a mistake. They make them in automated cars. They make them in space launches. There are mistakes in software, and so anyway, that's my thought on it. That that would derail confidence in AI if these accidents start piling up in significant numbers. Anyway, that's a quick thought of.
I'd like to make a comment going down that thread. I mean, Tesla has clearly made mistakes. People have died. And the marketing of their skill at solving this problem has been way overblown. So Tesla has always promoted that they were on top of it, was right around the corner, they were going to solve these problems. And it turns out it's much harder to solve than they've been leading on, because they're driven by a commercial application but that commercial application can result in tragedy and death, maybe less death perhaps than from driving down the road on your own, but even so. And so I think there's a tension between commercial application of something and the perception that a lot of money is to be made, and where the technology itself stands. Now, the other observation, of course, is in the healthcare field, the limits of what can be shared amongst patients and doctors about the healthcare of an individual, and how that's vetted and how that's directed is another complete set of guardrails that will appropriately, I think, slow down the adoption of some of this technology. And that's not what, and I don't have a question out of that. That's just an observation on what I've seen.
Thank you, Andrew. Much appreciation with that. And Sarah, I do see your hand up, so would love to give you an opportunity to speak.
Yeah, I was just going to kind of emphasize what Eagles just said. I completely agree with what you just said. And I wanted to emphasize that the importance of having independent replication of algorithms. So, right, if you have a data set and you have an AI tool or an algorithm that is instructed to find a relationship or develop subgroups, identify subgroups, it will do that. That doesn't mean that it's correct or replicable. So it's very important to then test it out in an independent data set in a non-biased way. And that's expensive. It takes a lot of time and money to do that.
Yeah, that it makes data that's collected absolutely essential. I mean, you don't want the garbage in, garbage out problem, right? And so the validation of data upon which these algorithms rely on, right? Absolutely essential. The quality of that data, the timeliness of the data, the relevance of the data, and correlations aren't necessarily cause and effect.
Right. And I would add an element that hasn't maybe been said yet, which is the developers of these systems. There's tremendous algorithmic bias built into the systems because of the individuals that are the nature and background of the individuals, the very limited nature and background of the individuals involved in developing many of these systems. I mean, I think we see very significant social media mental health issues already taking place, and research done by companies showing that they can affect happiness and depression with the tweaking of algorithms. So these are already versions of going off the rails, right? And so those are things that are very important to pay attention to and understand how to mitigate and put much more effort behind creating trustworthy, reliable, and inclusive diversity, equity, inclusion, and just forms of AI that that can better serve a broader cross-section of society.
Go ahead.
And also, a very simple one is when a person becomes imprisoned in a given change that the person wants to proceed, right? So when you rely so much on AI that you don't know anymore, like that you know less and less how to rely on yourself. That's a problem for me, from my perspective.
Thank you. I have another question in the chat box, so I'm going to read it now. In most cases of healthcare or in mental health care, care is a reactive medicine practice. How can AI allow more predictive care and wellness, especially with greater access to digital behaviors and health records? Any thoughts?
Well, I think this is one of the great promises of AI, the potential of being predictive. We've talked about it being personalized and so forth, but being predictive, I think, is probably one of the most powerful things, to be able to predict not only mental health, behavioral health, but also physical conditions, right? So that actions can be taken in advance before they become a crisis to an individual. And so things like suicide prevention and opioid avoidance and et cetera. So those kinds of things I think are terribly important. I think another aspect that I don't think it's touched on, maybe people have, but is the participatory element. I mean, the thing that one learns, I think, is that when you're interacting with peers, kind of peer-based, and as you try to focus on self-care, the idea of having peers to relate to become important. So AI can become a peer partner, I guess, but maybe there's a much bigger platform that could be developed that would allow larger groups of people to interact collectively, so that there might be, a collective value system and a collective motivation system that could bring people along, right? So it isn't just about individual treatment, but rather dealing with population groups, right, that might have similar issues and problems. And I'm just thinking out of the box here, but I think there's some potential there as well.
Thanks, Eagles. Any other questions from our people? I know if anybody's looking through the chat box, there's not necessarily questions, but certainly a number of comments that y'all might want to read through. But are there any other questions from our group to our panelists?
I have one question.
Please.
10 years from now, what would you like to see AI providing? What are the long-term goals that you see in the various projects that you're working on? If 10 years is too far, you can try 5, but nothing shorter than that.
Well, I'm betting on autonomy and personalization. A lot of the things that you see online about mental health, and also if you use ChatGPT or some other generative AI to make recommendations about a certain topic that you might enter or whatever. And I've done that search. Most recommendations are based on one of the widest schools in psychology, which is cognitive behavioral therapy, right? But is cognitive behavioral, I think, yeah. But this is just one way to approach a circumstance that is described, right? And sometimes it does not exactly allow to go into the essence of the I don't want to say problem, but it's the only word that comes to my mind. And sometimes these behavioral strategies are not sufficiently profound to transform your sense of agency and to transform the pattern in which you see your suffering coming around, right? But if you use ChatGPT and AI and generative AI, you will most likely be led to one of these approaches. So again, autonomy, self-knowledge, self-regulation. That's where personalized treatments. That's where I see technology having the most potential in 5 to 10 years in mental health. And learning and life changing and so on. It's like
I think some of the grand challenges in information science have been suggested as being a teacher for every learner and a team of one's own. So the idea that you could learn anything from an AI or potentially from other humans in that loop as well, and then the team. So you gather the expertise, whether it's avatars, robots, technologies, and people, into a team that allows you to do the kinds of things you want to do. And so, I mean, I think we have any number of specific disciplines ranging from creativity support tools to augmented decision-making and others where clinical AI, all of these are going to incrementally benefit as they have till now, right? So there's existing large deployments of AIs. And so, I think in the next 5 to 10 years, you start to see some of those improving dramatically. I mean, I think ChatGPT deployment was a major shift for the field of AI in the sense of understanding what is possible today in a forward consumer-facing approach.
Thank you, Wynn. We've got about 3 minutes, and I see Jess. Please, I see your hand is up. So Jess, if you've got a question, please ask away.
Hi, I've really enjoyed what you guys have all said. One of the questions I had is just with the fact that anyone can create a mental health app, and they can go in and they can, make it whatever they want it to be. Just for the general public, what are some things that we should look for in these apps to make sure that these are quality resources that we're getting, and not just, even how Wynn was talking about, there is a bias to it, and whoever created it has a bias. I mean, even some of the things that I've seen today, I would say, well, my dermatologist would disagree with that dermatologist. And so I think even just in that, how do we as clinicians think about what we recommend, or even what people are using in light of that, and what maybe are ways that we can say this is a quality product, this is going to give you a less biased view. So maybe just speak to that a little.
I can just say very briefly, I'm aware that the FDA has a new center for digital health, a digital health center of excellence, where they are starting to identify some of these quality control issues. So I can't say upfront, what to be aware of. I think you can kind of imagine where the possible pitfalls are. But there's definitely a lot of work to be done on sort of consumer education about how to approach and think about these kinds of tools. I'll put a link in the chat to this FDA center.
Thank you. That'd be wonderful.
Yeah, I think the basis of the question, Jess, is media literacy and trust, and trustworthy actors, right? And so looking at the combination of just where do you trust any social media? We have disinformation, misinformation. There's huge amounts of that online in other spheres as well, with and without AI. And that same question applies. How do you trust this individual with the information that you're receiving, and what kind of verification do you provide? So I would encourage the same kinds of approaches that, the FDA, other trusted sources. I mean, those get called into question in current society as well. So those are also part of the challenge, understanding, and people have even talked about a post-truth society, right? And thinking about what, your truth may or may not be my truth, my algorithm or desired app may or may not be your algorithm. These are further complications of your question, but ultimately I think it gets back down to, can you understand enough to understand if the sources of the information are reliable and trustworthy and uncompromised?
So a question for the panel, very short answer. Do you think that more computer scientists, more people in the computer field need to learn more about mental health disciplines, and more people in the mental health field need to learn a lot more about computers and AI and databases, etc.? There seems to be a tremendous need to try to put these two perspectives together for a successful outcome.
Definitely.
Do you agree? I see nodding heads. There we go. I usually don't get a yes to all my questions. Well, look, I think it's come time to come to an end here. Conrad, any final word before we wrap it up?
I think it's wonderful, all of the thoughts that have been presented here today. And we are at the cusp of a renaissance transformation of our society. And obviously, AI has poked us as a leading edge of that renaissance. We hope it will be a good renaissance. It usually is, but there's always the dark underside of everything. Thank you for coming.